So just tell me where to go in terms of where you'd like to start then.
You can go to the first slides and then we'll get to Michelle's recording,
Okay, sounds good.
my first slides.
And hi, this is Christy Musser. I just joined from Blue Cirrus. I apologize for being a couple minutes late here.
Oh, no problem.
Oh, fantastic, Christy. That works great for us.
I'll just listen in and then let me know where you want me to jump in or how you want me to, where you want me to participate.
Sounds great. All right, so I don't have to go through this. This is just a little bit about me. I'm glad it's on the recording in case anybody is interested and wants to go back and look at it. And go to the next slide. I do want to talk a little bit about the project that ComHET will be doing for the Office of Rural Health this fiscal year. Again, it's under addressing COVID-19 telehealth expansion needs of rural communities. We have expanded that a bit to where it's telehealth and technologies, as well as IT workforce training. So what ComHET is tasked with doing is enhancing CAH's abilities to send and receive data from the encounter notification services, which is really the Florida HIE right now. From what I've seen, all the CAHs, except for one, are actually data sources for that particular system. And that's an ADT, admission, discharge, and transfer, basically messaging that goes into that. And then others such as FQHCs, payers, they're able to get that information if a patient is admitted, discharged, or transferred from your hospital. What we want to do this year is make sure that either your FQHCs in your area are using it or others that you definitely discharge to. If there's a reason for you to receive information, maybe for interfacility transfers, things like that, to actually receive the ADT feeds as well, then we can help with that. The second bullet is assist CAHs in expanding broadband. So we've been looking into Starlink. We've been monitoring that, as well as the FirstNet, expanding FirstNet capabilities in all counties, which we can do that as well. With Starlink, I believe Hendry is the only one that can receive that, and we've let them know about that. The other hospitals will probably have to wait until 2013, but can reserve Starlink. So if anybody's interested in that, we'll definitely get in touch with them. We're also assisting CAH's HR departments with telehealth and HIT workforce training and workforce development resources. That's anywhere from free trainings, because we have a Department of Labor grant that can pay for those trainings and certifications that lead to credentials, to helping to set up apprenticeship programs within there, because we have registered apprenticeships with the states, and we also have funding for that, to helping with on-the-job training costs and things like that with the workforce development boards that represent each CAH's region. We're also providing ongoing technical assistance and support on rural telehealth. Right now, we're working mostly with Office of Rural Health to make sure that they get down to the metrics and understand the priorities that they have that meet a good business model for CAHs to use telehealth, because it's not going to work out if your reimbursement is not fitting for the type of telehealth program that you're trying to do. We're monitoring, as we did last year, rural telehealth and telemedicine policies and funding activities. You'll hear from Dr. Kim Landry today about what's going on in the state. And we're providing 3 virtual workshops. So that takes us to the next slide. Which is our first workshop. And we're doing that with Southeastern Telehealth Resource Center. And that's going to be the 2022 Florida Telehealth Forum. That will be at our headquarters at Kennedy Space Center. We'd love for people to come. I have a link to the registration there for you. The tickets are $75. They have great speakers. It's basically just to pay for food for you and for the venue. But you also get a free admission to the visitor complex for you and your guest or partner or family if you bring them down the day of the actual event and the day after. And let's go ahead and skip that one, Keenan, because Dr. Landry isn't available yet.
Actually,
I am.
it was on.
Oh, fantastic. Okay. Thank you, Dr. Landry. So go ahead, go back to that so I can make sure I introduce him.
Wonderful.
I know most people probably know him here, but so Dr. Landry, he's the CMO of Lifeguard Emergency Medical Service. I had to cut down his bio a bit. It goes on and on with all the wonderful work he does. But he is board certified in both emergency medicine and EMS. Got his medical degree from UF, and he did his residency and training at LSU. He has 24 years working experience in emergency departments and EMS for that as well. He's the president of Excalibur Telemedical Services, and they offer emergency physician telemedical services. And he's a fellow in the American College of Emergency Physicians. Dr. Landry, with that, I will let you take it away so you can inform us all on telehealth policy and trends in Florida.
All right. Well, good morning, everyone, and thank you for inviting me to give this presentation. So I have been involved in telemedicine for quite a number of years, and it's something that's kind of dear to my heart. And the more we can utilize it, the better it is for patients, basically, and patient outcomes and stuff. So if we can go to the next slide, please. So basically what I'm going to report today is just give you the state of telehealth in Florida, kind of the legislation and the trends. Next slide, please. So this is the definition of telehealth that the Florida legislators used when they drafted the telehealth bill. And it's pretty much the definition that was taken from the American Telemedical Association. The definition of telehealth and telemedicine, if you look on the internet, will vary significantly, and pretty much it's as simple as it could be just the provision of medical services to a patient when there's a distance between the provider and where the patient is located. But pretty much the Florida legislators used this particular definition, which was the use of synchronous or asynchronous telecommunication technology by the telehealth provider to provide healthcare services, which included but are not limited to the assessment, diagnosis, consultation, treatment, and monitoring of a patient. And basically, it has to deal with the education, public health services, and just other. It encompasses a very, very broad provision for providing healthcare services to patients. Next slide, please. All right, so I'll just give you a real brief history of how telehealth developed and was created in the state of Florida. So basically in 2016, a bill was introduced in Congress, House Bill 7087, ultimately passed, signed by Governor Scott, and it called for the creation of a telehealth advisory council. And it established that there were to be 15 members on this council. It included the Secretary of the Agency for Healthcare Administration, as well as the State Surgeon General. And each of those were responsible for selecting the remaining members of this particular telehealth council. I was one of the members of the council, and basically we met monthly for a period of time. And we were charged with conducting a survey across the state to look for current capabilities, the utilization, and the coverage level for telehealth services. After we were done with our a survey and putting a report together, we submitted the report to the governor, the Senate president, and the Speaker of the House. And they used our recommendations from this report to draft a bill to pass, which basically is what our telehealth legislation and statute is currently. Next slide, please. All right, so the other members of the Telehealth Advisory Council consisted of representatives from the health insurance industries that cover telehealth services, actual telehealth, healthcare facilities, which included hospitals, long-term care facilities, including nursing homes, entities that created or sold telehealth products, organizations that represented telehealth stakeholders, healthcare practitioners, which this was the category that I was selected, as well as organizations that represent healthcare practitioners. Next slide, please. All right. And as far as the survey, we were charged with implementing or conducting. It consisted of five primary topics. We were to look at the types of healthcare services that were provided via telehealth in the state of Florida, and look at what the national and state utilization of telehealth was, the cost and cost savings associated with using telehealth, the extent to which insurance coverage covered telehealth services compared to in-person services, and then the barriers to using telehealth. So from that survey, when we finished meeting, we put together this report right here, the final, the Florida report on telehealth utilization and access. This is basically a 31-page document that outlined our findings, and this is what we submitted to the governor, the president of the Senate, and the Speaker of the House. And they utilized the information and recommendations that we developed in this report to draft legislation to basically pass a law that outlined how telemedicine was to be used in the state of Florida. Now, the highlights of the report, what we found during our investigation and our research was that telehealth at the time was on the increase in terms of the usage of telehealth services, both in Florida as well as nationally. We found that at that time, 44.8% of Florida hospitals offered some type of telehealth services. In particular, neurology, teleneurology, and telestroke care was one of the major components. But also, home health patient monitoring was very popular and expanding. Primary care, behavioral care, and radiology. So these were all areas where we found were utilizing telehealth services at that time. We also noted that 44% of home health agencies used telehealth services for remote patient monitoring. And this has also expanded significantly over the past several years. The benefits that we found from utilizing telehealth services were improved convenience for both the patients and the providers, improved efficiencies, and improved patient care outcomes. We also found the financial barriers are the most frequently reported obstacles to utilizing the service. Because of conflicting definitions of telehealth and telemedicine, there was some uncertainty with the type of services and activities that were covered for reimbursement. We found there was a significant challenge with interoperability between providers across the state and nationally. In other words, we had trouble, or services had trouble, when you encounter a patient via telemedicine to observe or look at the patient's medical records from another organization or another healthcare entity. There was no integration that allowed one service to look at the medical records of another service to kind of coordinate, and that was somewhat of a problem. And actually, it still is today. We found few providers had achieved financial return of investment when they participated in telehealth services. And in general, there was a lack of detailed knowledge about telehealth services, that practitioners simply had no interest in using it. All right, so once we completed our presentation and sent this to the governor, the Senate, as well as the House of Representatives, they drafted a bill, House Bill 23, telehealth services. And what this bill ultimately did was it authorized Florida licensed healthcare providers to use telehealth to deliver services within their respective scope of practice. They also kind of required that, you know, if you're going to provide a service via telehealth, you must maintain the standard of care. It has to either meet or exceed the standard of care. You cannot provide substandard care using telehealth services. It also authorized out-of-state care professionals to use telehealth to deliver healthcare services to Florida patients if they were registered with the Department of Health or the applicable board, they met certain obligations, and they paid a fee, or if they were licensed in the state of Florida. So you could live in Florida, and if you wanted an out-of-state physician to manage your problem, that physician would have either had to be licensed in the state or registered with the Department of Health. And this basically is still in effect today. During COVID, they did waive this and allowed non-licensed physicians in Florida to provide service to patients in Florida. But that particular waiver sunsetted, and I think in July of 2021. Now, the bill they introduced also established standards of practice for the services using telehealth. Now, it took several years once the bill was introduced and going through the House, going through the Senate. They made changes, amendments, and ultimately in 2019, they passed the Telehealth House Bill 23. And it was signed into law again by Governor DeSantis. And it was Florida Statute 456.47. And it basically established the standards of practice for telehealth services. And so basically what's in the bill, it requires, or it defines, the services, the types of patient evaluations and how you conduct those patient evaluations. Record keeping is part of that legislation as well. Controlled substance prescribing. Initially, there was a prohibition on describing controlled substances via telemedicine. And then also out-of-state practitioners that perform telehealth services for patients in Florida, again, were required to either be licensed in Florida or they had to register with the Department of Health or the applicable board that they belong to. And this was kind of an example of, if I'm a physician and I have a patient here in Florida, but I need to consult an expert at a university center in Michigan, for example, that physician was able to come in and assist me in evaluating that patient and managing that patient without having to be licensed in Florida. But they did have to kind of register with the Department of Health or the Board of Medicine. So it wasn't until April of 2022 that an amendment to that original bill was passed or made. And that amendment did kind of relieve somewhat the prohibition on the prescribing of controlled substances to patients. It's still somewhat restrictive in that you can prescribe controlled substances, but it has to be for a patient that's in the hospital, a patient that's in a nursing home, a psychiatric patient, or a patient that is on hospice. So it did kind of ease up a little bit and at least permitted those 4 areas of prescribing controlled medication. But I think that could be expanded even further for acute injuries and emergencies such as I encounter on my as an emergency physician. All right, so now what I want to do is I want to just basically review with you. There are 6 basic models of telemedicine and telehealth. And if you just name a telehealth program, I can pretty much plug it into any one of these 6 models. So these first 3 models that you see here actually involve a physician that is caring for a patient through a telemedicine, telehealth, through a distance. The first model, for example, uses an extender that is at the patient's side. And an example of this would be what I'm involved in is Tele911, which is, as an emergency physician, as an EMS physician, I help a paramedic from an EMS service that was dispatched to a patient's home for an emergency. It's identified by the paramedic on scene that it's not really serious enough to be transported to the hospital. So they now have an opportunity to contact the Tele911 physician, who comes into the patient's home through the paramedic's computer and basically can assess the assess the patient with the help of the paramedic and then we can come to a conclusion if the patient can be treated on scene, does require transport to the hospital, or we can send to an alternative location other than an emergency department. That's just but one example. Another example would be if you've got a home health nursing agency that's at a patient's side and needs to contact the physician for change in medication, a change in a patient's condition. That physician could basically, again, encounter the patient with the extender present and examine the patient and make changes to the patient's orders. This would be a prime example of how telemedicine could be used in rural communities. If you've got an EMS service in a rural community that responds on calls, and the closest hospitals an hour plus away, they can certainly utilize the tele 911 service to come into the patient's home, help assess the patient, help manage the patient, and even make a determination if the patient can be treated sight on scene or maybe sent to a clinic in the local area as opposed to a hospital that's significantly out of town. So there are a number of opportunities for the use of this first model in the rural health community. The second model basically incorporates a specialist, an MD specialist assisting a physician at a, say, for example, a critical access hospital that may not be board certified or may need an expert opinion on something. And the specialist physician can assist the local physician that's with the patient in the emergency department or anywhere in the hospital, and basically conduct the exam together and make a decision on management of that patient. So again, this is an opportunity for critical access hospitals to basically call in for a specialist to come in and assist the patient without having to transfer the patient from the critical access hospital to a larger facility. It could be many miles away. So another opportunity for that. This third model is kind of a direct physician to consumer platform. And this is going to be things like your Teladoc, American Well, and where the physician directly communicates with the patient through their cell phone. And basically, this particular form of telemedicine is somewhat limited in that the physician can only offer an evaluation based on what he sees through the telephone or the computer without anyone at the bedside to help the physician with a more extensive exam. But nonetheless, one of these three models, you will have a physician directly involved in that patient care with or without an extender at the patient side to help that physician. These next three models basically involve not necessarily a physician, but it could be a dietitian, it could be a nurse practitioner, or a home health agency that basically monitors patients and helps to manage patients in their home environment again. So the first model here is a lot of the home monitoring systems where patients are discharged from the hospital or require some close monitoring at home. So they're equipped with a digital scale, a thermometer, blood pressure, and various monitoring equipment that sends the data to the program at some distant site. It's processed into the patient's medical record, ultimately reviewed by the doctor, and then changes in the patient's care can be offered through this particular model. The second one, number 5, is where you actually have, again, someone present with the patient. Maybe they don't know how to use the digital thermometer or the digital equipment. So there's a nursing assistant or maybe even a home health nurse present with the patient. And then they provide the data to the central monitoring system. It's processed, put into the patient's medical record. And as long as there's no emergency condition that requires an urgent intervention by the physician, then changes to the patient's medical records and regimen can be made, and patients can be prevented from going back to the hospital and being admitted to the hospital. They could basically continue their care at home. If something urgent comes up, the physician could have the option to intervene immediately with the extender and try to remedy that problem. And then that last model basically is a service where you've got an extender or patients calling for advice, and it goes to like a nurse navigation line where the nurse listens to the chief complaint, obtains certain amount of data, and then they refer the patient over to whatever services that are available for the patient. All right, so what are some current uses of telehealth in Florida? Again, I mentioned Tele 911, and this is basically a service where a board certified emergency physician in Florida is available to any EMS service that responds to a call. And there's some question if the patient even needs to be transported to the hospital. The emergency physician, along with the paramedic, while they're in the patient's home, can assess the patient and make a determination if we can treat the patient sight on scene, send them to the hospital, or maybe even refer them to a clinic or a private doctor's office. There's things like community paramedicine programs. The Mayo Clinic in Jacksonville is an example of this, where they have hospital to home services where patients are discharged from the hospital. They sometimes still require hospital services, but those services can be provided in the patient's home. So monitoring equipment, again, is set up in the patient's home. Paramedics will go into the home, assess the patient, enter data, including the vital signs and whatever other data is necessary or that's being set up to monitor the patient, and reports back to the hospitalist. At the hospital, and then together they monitor and they make changes to the patient's orders and continue to care for these fairly sick patients, but doing so in their patient's home. Teleneurology is probably one of the most popular services that are offered to hospitals in Florida, where you're not a stroke center, you're a small community hospital, a patient shows up with stroke symptoms, and now you're not sure, if they need TPA, if they need to be transferred for a higher level of care. You can basically have a neurologist come into your emergency department through a teleneurology program and have the neurologist assist you in evaluating the patient and making a decision if the patient needs to be transferred to a higher level, or if they can be taken care of right there in your own hospital with either continued monitoring or maybe some TPA or what have you. So teleneurology is a big service. There are a number of home health programs which do remote monitoring. They set you up with a scale, a thermometer, blood pressure, pulse oximeters, and all these various data points are automatically transmitted to a central receiving station. They're processed, put into the patient's medical records, and you can monitor a patient's health care fairly close using this type of service. There are tele-ICU programs where you could have a patient in an intensive care unit, and you're in a small community hospital. You have no intensivist, so you can basically arrange for a tele-ICU doctor to come in periodically, daily, hourly, however the contract is, to evaluate these patients and prevent these patients from having to be transported out at times. And so there are many specialty programs that use telemedicine. There's dermatology, cardiology, pediatrics, et cetera. So more and more specialties are offering telemedical services, dietitian programs to help you with your diabetes, just a number of different programs like that.
Dr. Landry,
Yes.
I think we're probably going a little over time. Everyone will have access to your slides. The burning question that they have right now is, how can critical access hospitals get reimbursement for doing some of these programs? Because they're in, and I'm not expecting you to understand about the reimbursement piece, but what do they need to do? What steps do they need to take in terms of advocacy to get to legislation that allows them to get paid at least similar to their counterparts that are health professionals, but not at critical access hospitals?
All right, so that's basically the main obstacle right now is reimbursement, and that we try to put in the original legislation language that would allow for parity, where you are reimbursed at the same rate for providing services through telehealth as you are for in-house, in-person services. That language was stripped out of the bill, and it basically failed. So right now, payment is based on a couple of ways. You would either have to contract with a medical service that offers this telehealth program, or if you're relying on the reimbursement from third-party payers, it's what you negotiate with the third-party payers to reimburse you for that particular service. I know Medicaid pretty much does reimburse by a parity. In other words, Medicaid will pay for services the same as if it was an in-person, but a lot of third-party payers will not. It's more a negotiated rate, and sometimes that just doesn't. That's very substantial, or it's very low. You just can't do that. So there is no answer to that right now. It's a matter of you negotiate a contract with the telehealth services, or if you're going to rely on billing third-party services, you have to negotiate what the reimbursement is for a particular type of a service.
Would you like me to go
We
forward in
appreciate
the
that.
slides then, Kendra?
Yes. Do you want to go to the, is it okay if we go to the summary slide,
Sure.
Dr. Landry? Okay.
All right. So basically, we've got believe it or not, we do have a pretty solid telehealth law. Like I said, the only thing that really disappointed me was the fact that they carved out the reimbursement component of that. But there are opportunities for telehealth services to be expand in Florida if we could overcome these barriers. Patients that receive care through these services are extremely satisfied. They like the efficiency, the privacy, and the convenience of telemedical services. They don't have to travel. They don't have to take off of work to go pick up a kid, to go to the doctor, lose income. So there's a host of cost savings when you use this kind of service and stuff. And I just think the more rural the community, the greater the benefit of telehealth services with respect to getting care to a patient that normally doesn't have care. They wait till they're so sick. Now they have to be admitted to the hospital. And so we've got a lot of opportunity to do even more with telehealth services here in Florida.
And if I may jump in with a very quick question, it's Peter Cottrell from North Island. I mean, you mentioned obviously that the carve out of the reimbursement. I mean, is there any opportunity? Will there be any opportunity given coming out of the public health emergency to reflect on, the fact that obviously the waivers were very helpful. The revisiting the legislation. Even if you have a solid law, the fact is there are still those barriers to uptake. And so, and to Kendra's point about advocacy, is there any plans? Are there any opportunities to sort of push things so that in the next session or two of legislature that things like that could be addressed?
Yes, there is, but the only problem is the insurance industry has a very, very strong lobby and presence in Tallahassee. And so you would really have to deal with the insurance lobby that is very protective of this language and preventing it from getting into the bills and stuff. So if we could overcome that, yes, we might can try again. But looking at other things like the inefficiency in getting medical records from one organization to another, the interface between that needs to be addressed, as well as the connectivity issues. A lot of rural communities simply don't have good cell phone service or Wi-Fi service that permits for this. So there are a couple of things that we could push for to improve on the bill that's out there now that would particularly beneficial to rural communities.
Thank you so much, Dr. Landry. And
Welcome.
we will look forward to speaking with you again too within the next year. We'll have workshops. So
Yeah,
All
thank
right.
you so
Enjoy
much
this.
for your flexibility, and it's a great presentation. Is there anything the community can do to try to get this reimbursement thing pushed through? Any suggestions?
Talk to your legislators and basically plead the case and stuff. And like I says, it's a matter of whose lobby is has a louder voice in Tallahassee. So if we can get a good advocate for the healthcare product and the benefit of it, and just really, it's really worth the effort to try to get reimbursed appropriately for this. And yeah, it's just a matter of you talk to your legislators and let's try to get us a good lobbyist.
Okay.
I-
Persistence.
Yeah,
And Leela has a question. Leela Shepherd, Director of
Yeah.
Office of Rural Health.
Thank you. Thank you so much. Thank you, Guy, for your presentation. And I just wanted to, on that note, encourage the hospitals to work through your different advocacy organizations and nonprofits. And I know that Florida Hospital Association and other organizations that do education, and then even the lobbying piece and working on these policy issues. I encourage you to work through them, maybe there's something you can do as a group, either as CAH or there's small rural hospitals throughout Florida that aren't CAH. But I would reach out particularly to the Florida Rural Health or Hospital Association. And I don't know if Kendra and Sarah, if she's on the line, have thoughts about that. But I know with the Office of Rural Health, we can educate, but we're not to lobby or advocate for legislation. So, but I would encourage you to work, if you want changes, to work through those outlets.
And we're certainly happy to help with that as well, Leela, with FHA.
Thank you. Yeah, great. Thanks, Kendra.
Thank you so much, Dr. Landry. I know
You're quite
super
welcome.
busy
Thank
too,
you.
so.
Yes, thank you very much.
So I don't think Lloyd is on the call yet with us. And
Okay.
he's the CEO of the Southeastern. Is he on?
I don't think so. I don't see him on the
Okay.
call here. So
Yeah, he's the CEO of the Southeastern Telehealth Resource Center. So I just wanted to let him speak for a couple minutes when he gets on.
Yeah.
So we can go ahead and skip that and go on to Blue Cyrus Consulting, the next slide.
okie dokie. Perfect.
Yeah, and Michelle, actually, she left us a video recording because she was out of town. She does have folks on the call to answer questions for us. If there's anyone on here right now, if you want to kind of say hello.
Hi, this is Christy Musser. Thanks for having me. My headset has kind of got my hair messed up. Uh, thanks for having Michelle featured. She's did a great recording that she put together last week, and excited to hear that. If there's any questions, please put them in the chat. I will can respond to them if I have immediate answers, and I would love to then take your information back if there's any follow-up.
Perfect.
And with
Thank
that,
you.
we can start the recording, Keenan. Thank you.
Excellent. Perfect. I'll pull that over. So let's just make sure we can all hear it here. Okay. How does that sound?
I can't hear it yet, Keenan.
Peter,
you're on mute.
Sorry. You need to try stopping sharing, reshare again with the computer audio enabled. That's what I did. What I found worked for me last time.
With the say it again.
So now when you click on the share and then just click on the button that says computer audio share enabled.
There we go.
Yeah.
Perfect. Perfecto. All right. And let's try this again.
Thanks so much for having me. I'm Michelle Hager from Blue Cirrus Consulting, and I actually have with me Christy Musser as well from Blue Cirrus, and she's going to help with some of the question and answer session at the end of this discussion. A little bit about me. I am the managing partner of Blue Cirrus Consulting. I have over 20 years of healthcare IT experience. And from a telehealth perspective, I am on the advisory board for CTEL. Also been a vice chair for public policy for HIMSS. And I've also recently inducted as a fellow in the College of Fellows for the American Telemedicine Association in this last, at this last ATA. About what's possible with telehealth, specifically for the critical access hospitals and for rural health clinics. We're going to be focusing on some of the impacts of the timelines of the waivers, some public policy that you might be able to do, building on what we know is already going to be the case, and then preparing for what happens after the PHE is over, because I know for some folks that's a question about whether or not I should even continue to do telehealth or what I should do afterwards. And then finally, we'll give you some resources and tools to take with you and be able to use in your own practices. So first of all, for rural health, from a past, present, to future, obviously prior to the pandemic, we had wide swings of extreme barriers in reimbursement, and it was just sort of all over the place at that point, as we all know. But then when we see the public health emergency, we see a majority of those imposed limitations and barriers were lifted temporarily. So this is obviously something that this group is aware of, but what's important is obviously we don't know in the future what exactly will be the case, but we do have some clues based on some legislation that is coming through and also some discussion that we know from our conversations at Capitol Hill and also with congressional panels. So a couple of things that could happen with the timelines for the PHEs, and some of this you may have kind of in your toolbox. And if you don't, this is a great slide to just kind of keep. And we'll share those slides as well as part of this presentation. But the way that the PHE waivers will work is the end of the federal PHE waiver right now is extended through October 13th of 2022. And then we would have an additional 151 days. So essentially through March 13th of 2023. However, there are a couple of different scenarios that could happen. We could have the end be another 90-day extension, in which case it would be on January 11th, 2023. And again, another 151 days, which would take it all the way to June of 2023. However, we have heard and have been seeing some discussions around potentially having it go through the end of calendar year 2023. Part of the reason why the 151 days was they had in July of 2022, when they expected the PHE to be over, they said, well, 151 days from there will be kind of the Medicaid budget timeline. And so it would be before the Medicaid budget timeline. However, now we're into an October timeline, so that deadline is not going to be in play. And of course, we're talking politics, so 10/31 is roughly a week before the midterms. Depending on which side of the fence you're on, that might be a good thing to not extend the PHE and make one side look bad, or to extend it and make the other one look good. It's just a crapshoot there when it's not sure what will happen at the end of that one. But it could go through the end of 2023. And then finally, if we do see the end happen at the end of the calendar year of 2023, then that would mean that the PHE waivers would go until, April of 2023. Those waivers would be extended another 151 days and then go through to September 9th of 2023, or again, through the end of the calendar year 2023. I hope that made sense. This is all about whether or not you get a notification 60 days out. So we're always looking for 60 days out. So in the case of now, we've got one through 10/13. So 60 days prior, we'll be looking for a notification of an end to the PHE or a continuation. Usually what we get is nothing if we think it's going to, if they're going to continue. But if it's going to be end, if that's going to be the last one, they'll give us that 60-day notice. So again, we'll know something by August 12th or so if we will have an additional extension. So from an advocacy perspective and public policy, what we're seeing just from a, because this is so volatile and it's so dynamic, we know that the Federation of American Hospitals, which represents all the managed hospitals, investor-owned, et cetera, they're urging them to renew the public health emergency through the end of the calendar year 2023. So not only are we seeing a push from individual organizations and physicians as well as the AMA, but we're also seeing that being pushed from the hospitals as well. It's just a little bit difficult for them to be able to handle it. So this matters in terms of reimbursement, because as long as those waivers are in place, then we have a greater flexibility from a critical access hospital and a rural health clinic. And then finally, we've just seen the HR 4040 be passed. This is the bill that was sponsored by Liz Cheney as well as Representative Dingell from Michigan. And this includes quite a few of the requirements that we hope to continue, including extending the critical waivers through the end of 2023 in rural health, removing the distance and originating site geographic restrictions. In addition, it also puts off the requirement for the in-person requirement for a mental health visit. So that's really important elements that we'll see coming through in HR 44. It looks like it has overwhelming bipartisan support and is suspected to pass through the Senate. But this is politics, so you just never know what will happen at that point. There's also another bill to keep an eyeball on, which is the Connect for Health Act as well. That continues to bubble through. That is sponsored by Senator Schatz from Hawaii, as well as 20 or 25 other co-sponsors. So quite bipartisan in terms of its approach. And then don't forget that at the state level, you also have specific laws that are governing Medicaid itself. Even though your PHE is over in Florida, we do know that there are some specific laws that are governing telehealth in Florida. So when you look at the remainder of the PHE and the 151 days post the PHE end, so could be the end of calendar 2023, or as we said, these different times, here's some codes to be consider of and elements that you may be able to bill for and that you should be able to bill for. For rural health clinics, you're going to qualify to furnish distance site telehealth services. And as we said, HR 4040 is removing the distance site or originating site geographic restrictions. And then you can see the code to use there along with G2025. So there's the charges that you can drop for telehealth services. And Christy, I know you're the expert on this. Anything you want to add here?
Really just to, being a distance site is that one thing that changed during the pandemic, right? You've always been able to be originating site, but now the distance site is in play. And that G2025 did have some adjustments throughout this last year, which I'm sure you've all known and experienced. And if you haven't gotten your adjustments, please make sure you work with your Medicare carrier. But these are the codes to report as of right now. Once the pandemic ends and we enter into these 151 days, there may be updated billing information that you'll want to watch for.
Absolutely. And then on the inpatient and observation services, we are seeing additions of services, including admission and discharge for the observation pro fee. And then, of course, post would be the lifting of the pre-COVID frequency limitations on subsequent visits. Again, Christy, feel free to jump in on those final two as well.
Sure. So what we really saw in different during the pandemic is the inclusion of the ability to do admission and discharge services via telehealth versus only specialty consults. and critical care and telestroke. And also the subsequent hospital visits had a 1 in 3 day frequency limitation that has also been lifted. So until the end of the PHE and then the post grace period, you will continue to be able to bill for that in the hospital observation, inpatient observation settings.
Great. And then the digital and virtual communication expansion, we know that the audio only services were available there. And then we also know the G71 is available for digital online assessments. And I'll turn to you for some additional data around that as well, Christy.
Sure. And this is something that was actually in play before the pandemic went into effect, but was not widespread in use or adoption, but it really has surfaced and will continue. And that's your ability to communicate with patients either via phone or through an online portal communication, and use this G0071 to indicate that you have communicated with the patient and documented some advice. And we're going to go into those guidelines in a couple of slides.
Exactly. So let's build on that foundation of what we know was already true prior to the pandemic and will continue post-pandemic. And then we'll talk a little bit about what the unknown is. So from the known side, right now, we form an originating site. You continue to act as an originating site for telehealth services. Expand your specialty services. You're still an originating site, so you're still able to receive and provide specialty services to your patients in your offices, and extend those services from other organizations. And then utilize your rural health residents, trained nurses, other facilitators, and other clinicians that you have access to, who can also be part of your telehealth service in order to, as you see here, capture higher acuity patients, but also sometimes it just increases your capacity, allows you to sort of offload some of the work that you might have as a physician and allow some other providers who have the ability to do that within their scope of practice. Again, allowing them to work at their top of license. And then collect your fee. Collect that originating site fee, and continue to bill for that. So this is a capacity building approach. This allows you to be able to take some of the services that you need to receive and get those from other organizations, billing your originating site fee, and then utilizing some other clinicians via telehealth to be able to reach more patients, potentially see more new patients in your office. From a mental health perspective, effective in January of 2022, which this will be effective post-PHE, we know that rural health clinics can receive payment for mental health visits that are done through telehealth technology. So this is one of the areas where we see the majority of the business or the reimbursement being done through mental health services. We see a lot of reimbursement push for mental health services. So if you're considering doing that, it's a great time to do it. It's going to continue to be paid for, and you'll obviously be able, there's such a need out there, you'll be able to care for your patients even better via telehealth. And it makes complete sense to do telehealth for mental health services. There is actually no reason from a clinical perspective, they don't have to touch the patient. In fact, many clinicians in the mental health services, they do not touch the patient based on the type of service they might provide, but certainly it makes complete sense to be able to do therapies, and we know there's a variety of different technologies to do that on. Audio only is acceptable when the patient doesn't have or isn't willing to use video. So you're able to utilize your modifiers, FQ for CMS and then 93 for other commercial payers, but you can use audio only when the patient is not willing to be on camera. And then finally, the in-person visit once every 12 months, which will be in the PHE, or potentially we know that there's some legislation saying every 6 months, but just to make it confusing, HR 44 is saying we might want to get rid of that completely. So again, that's very popular right now to remove this sort of arbitrary in-person requirement. And the difficulty with putting an in-person requirement is not only is it not necessary clinically, but it also doesn't help with the challenges that we have with provider capacity, whether it's physician capacity, nurse capacity, or psychiatric capacity, given what we have in care needs over the last year and what has been exacerbated during COVID. Anything to add there, Christy?
No, really, this is something that I think is a win, that this has been passed, and we know it's one of the knowns, because mental health is there's such a huge need for this, and you'll be able to continue to provide these services to patients in their home via telehealth, and really, and even that audio only piece is a huge win. So this is no little piece. I think this is big, and make sure that you have your strategy built out for this.
Absolutely, absolutely. And then digital communications, we know prior to the PHE, we had virtual check-ins. So those are still in play. Those are still going to be available post PHE. And these aren't necessarily related to visits that you've done in the last 7 days. However, you can prompt the patient. You can say, don't forget, you can contact us through computer-based technology. You can do that through a messaging, secure messaging, any kind of portal. And the physician can communicate back and forth with the patient, and that is a billable service. This is something you're probably giving away today, and is probably you're giving away free. Maybe your nurses are doing this, or some other clinician in your office. You can do a virtual check-in through those digital communications and directly interacting with a billing provider, and be able to again bill for those services that you probably are giving away for free right now.
And this, I would say, would be something that would be that bridge. So if audio only does go away for everything except mental health, this is something that you can keep in play for some of those lower acuity triage kinds of calls, and still be able to provide some level of care for your patients, audio only, in between visits as needed.
Absolutely. And we've also included all the links for everything that we've talked through here. So if you want to learn more or read more about the topic, you can also click on those links. There's also inpatient telehealth services that you can utilize, telestroke, obviously, to reach those patients quickly in order to minimize any long-term damages that might be happening to them during a stroke. Critical care consults for those in a critical access hospital. You may want to keep those patients in your hospital for as long as you possibly can, if you can raise the acuity level by getting a consultation from a distant site. And specialty inpatient consults. These are also services and as services that you can provide, as well as provider-to-provider consults. And the critical care consults are not only keeping your patients there, but they're also billable for those physicians that are providing those consults.
And just remember that the specialty consults, again, those follow-up consults, pre-pandemic, it was the 1 in 3 days. Frequency limitations right now, you could potentially have every day be via telehealth, but that may change and revert if things are not extended.
Good point. Don't forget, for those that are working within a larger potentially health system where maybe your medical board doesn't have credential by proxy, you can do this by adding this to your medical bylaws. You can do this also just in organization. So you got a distant site, an originating site, and your organization might want to be able to transfer or use clinicians from either organization and use them really easily. You can use a function called proxy credentialing, which allows the organization to accept the credentialing and vetting that has been done by the distant site entity. It needs to be a written agreement between the two organizations, and you have to report the data, obviously, back between the organizations. But this is a great way to be able to extend and utilize clinicians from multiple facilities.
And that really works in building your strategy on the inpatient side and keeping those patients in your critical access hospitals by bringing the specialty care to them, whether it be telestroke or other specialists that are conducive to a telehealth visit.
So let's talk about the unknown for just a minute. So if we do have the waivers extended or made permanent, Obviously, we want to match our strategy to identify the areas of need. Mental health, we've already identified as a big need and a big area where billable services are going to continue to be put forward. We know that wellness services, preventative services, that makes complete sense. And then, of course, chronic care follow-up and maternal care. In some states, and I think Florida is certainly one of them, where the maternal fetal mortality is very high, it's a great way to utilize telehealth to manage patients that have preeclampsia, patients that are not compliant with other services and treatment plans. It's a great way to extend to your patient base. On the audio only side, identify appropriate expansion for audio only beyond the virtual check-ins that we just talked about. Create some guidelines and workflows. This is really important when you're doing any telehealth program. Tell the clinicians, identify what the care plan looks like, what the protocols look like, put those guidelines in place and what those workflows look like so they know exactly when and where they can utilize telehealth. This isn't a replacement for an inpatient in-person visit. This is a part of your protocol, part of your care plan and your clinical guidelines for a particular patient and their diagnosis. And then educate patients, families, and staff on how telehealth can work, how the audio-only process works. For RHCs, you have the ability to continue as a distance site, identify those high value services, things that you might be able to do from a nursing home perspective or wellness. And then also, same as we saw with the audio only, educating patients and families, but also identifying your workflows. As we said, very, very important to understand how you're going to utilize that from a clinical perspective. And that will help you with increased capacity and help you with some after hours visits and reducing your cancellations and no-shows.
I'm going to pause here really quick because we are running about 10 minutes behind, and I want to provide Jeff with the proper amount of time to speak on the next topic, PHE transitions. The wonderful thing about this is that this is recorded, and that was a wonderful setup that Kendra did with her team. And so before we jump and leave, I know we have Lloyd Simmons on the call, and I wanted to give him the chance to kind of speak to some of the questions. I think Kendra's still on the call as well. So let me jump out of here.
Thanks, Keenan. If you could go back to the slides, to Lloyd's slide.
Yep.
And Lloyd Sermons, he's the CEO of the Southeastern Telehealth Resource Center. We work closely with them on all of the telehealth expansion in the state. He was kind enough to connect us to Michelle as well for her wonderful presentation. And Lloyd helms the group that we're doing that forum with. So Lloyd, if you want to just talk for a couple minutes.
Yeah, I'll be quick too. Because I know. Oh, let's see. There we go. I'm hearing an echo. Can you hear me now? There we go. All right. So yeah, I'll be quick. I know how it is to be in a meeting and kind of get a little bit off, and I like to try to keep things on track. I apologize for not being here sooner. We're actually doing our work group meeting, our Georgia work group meeting, and so was kind of busting through that. But just really want you to know that, we serve as the Southeastern Telehealth Resource Center. Florida's in our territory, and we provide technical assistance around telehealth and telemedicine. And those services that we provide are free. So if you ever have questions, you have anything maybe around equipment, policy, reimbursement, those type of things, we'd be more than happy to assist in any way we possibly can. We do education around telehealth and telemedicine, whether it be telehealth 101s, those kind of intros to telehealth and telemedicine. We speak at conferences and things, and as Kendra mentioned, we're working with Kendra and them on a one-day forum down at the Kennedy Space Center there, and would love to have you guys join us and be a part of that. But if I can ever be of assistance, please don't hesitate to reach out. We're here to assist in any way we can. And just like with, with Michelle's group, not saying that I have all the answers, that I know all the answers, but, we have built out a network large enough with all the resource centers around the country. There's 14 of us total. If I don't have the answer or the resource that you need, there's a really good chance that we can get that resource for you or get that information. So I'll turn it back over to you guys.
Thank you, Lloyd. And I see Kendra wanting to chat here. I'll let you go.
Thanks so much to Lloyd, and I was thanking you, Keenan and Peter, for allowing us this time.
Oh no, the pleasure's all ours. The pleasure's all ours. Okay, there was some echo there. The pleasure was ours, and thank you for your flexibility and for all of the speakers being able to jump on. I think it still went off smoothly, and the nice thing is we got a recording, so everybody can watch it back later if they have any other questions. I'm gonna move forward here, and I know I promised everybody a break, so as we kind of come to the next pieces here in the presentation, please turn off your cameras, feel free to grab water, stretch a little bit, but in order to save time and allow Jeff to have his hour here to speak, I just want to get started and let him get going. But Jeff, I see you on the call. Thank you. Welcome for joining. I think you're back in your office, so I'm sure that's more comfortable than the usual travel. But I'm going to hand it over to you, and I know you got a good slide deck here to go through, so the time and the floor is all yours.
Well, Kenan, do you have the slides, and are you advancing them, or do you want? Yeah, there we go.
I've got them, and you just tell me next slide, and I'll go to the next slide for you, sir.
That sounds great. So you want me to start right now, just so that we can make
you can slowly introduce yourself and let people just I'll let people do their thing, and then it's obviously recorded, so.
Excellent. Thank you, sir. Many of you know I've worked with North Highlands and the state of Florida for the last 3 or 4 years, and I am a rural health consultant. I'm certified in healthcare compliance, and I work specifically with rural health clinics and critical access hospitals. And I work and I have clients in 39 states. So I've got the Medicare down fairly well, but of course, each state's Medicaid has its own unique twist, but I do have a few slides on Florida's Medicaid situation that we'll cover. But what we're first going to cover is what changes will happen when the PHE ends. And I've already heard from the last presentation, which was a very good one, on many of those things, especially how it affects telemedicine, but we're going to address almost every area of a critical access hospital and a rural health clinic, those areas that are touched by the waivers and such that we need to be prepared for. Next slide. As all of you know, the PHE was established January of 2020. And as of right now, it is continuing on. It was renewed in July the 15th. The next renewal in the 90-day increments will be October 13th. And as you probably know, that it was communicated in the last presentation, though the PHE is extended every 90 days, it is required that they give you a 60-day notice before it ends. Well, if we do the calculation, that means that on the 14th, which is 3 days from now, if they do not let us know within 3 days, it will not be ending in October when this extension runs out. And so we can be assured that between now and October 13th, that we've at least got every day, at least 60 days ahead of us, that we're still going to be in the PHE. And there are certain things that have changed and haven't changed. There's a rule about 151 days, which that was addressed last session. Well, we're going to deal with some of that in this topic. So what I plan on doing right now is to, at a high level, especially based on time, go over the waivers that specifically affect critical access hospitals and RHCs. Next slide. Well, two of those blanket waivers that we have to address is the EMTALA waiver, which basically gives us no enforcement of some of the issues that would have normally been enforced, which I have tried in most of these cases to put the actual references to that, but that will go away at the end of the pandemic. And so our concerns about EMTALA that we've always had will be heightened once this goes back, because now we will not be able to do things off-site. They will always be on-site. The same thing with verbal orders, and I'm referring to primarily medication verbal orders. There has been a lapse in that regulation to give us a little bit more flexibility during the pandemic. But that too will go away. And let me stop right now and explain something about a public health emergency. When a public health emergency is declared, Regulation 319 of the code, it gives the Secretary of HHS the power to issue waivers. However, it does not necessarily, though they're not automatic in the sense that every PHE will create these amount of waivers. That is at the Secretary's discretion. So let me explain. On August 4th, which was 7 days ago, the Secretary declared a PHE on monkeypox. Well, what does that mean? Well, we don't really know what that means. That was done 7 days ago. It does mean that we are going to be in a PHE for that virus, for monkeypox. However, the Secretary has not given us direction as to what waivers, if any, will be provided. What that PHE does for monkeypox is it gives us better access to vaccinations and a speedy process of determining those vaccinations and distribution and education. But as far as waivers, we don't know. So at this point, the best assumption for your hospital and your rural health clinic is to assume that this PHE, when it expires, the waivers expire with it, where the other PHE, until the Secretary tells us otherwise, these waivers do not apply. So that's how PHEs and waivers go hand in hand, or they don't go hand in hand. Next slide. Two other waivers that we have to address is that the masking that's required in sterile compounding has been laxed, so that now we can reuse face masks. This was all done so that we could save on scarcity of masks. This is still intact, but what I would highly recommend is that some of these that are no longer necessary, that we go ahead and comply as though the waiver is gone. And that's what I would do in the sterile compounding area. The other area is the detailed information sharing that takes place when we are discharging and planning for discharging in a critical access hospital. This is referred to in 485.642A8 that tells us how we are to communicate and share information between those facilities. But knowing what happened during this PHE, that was once again a requirement that was not enforced, but it will be soon as the PHE is over. And considering that we are not in the same condition we were in other times, such as November of last year or May of last year, I would go ahead and roll back into the detailed information sharing for discharge planning that you'll find in 485.642. Next slide. And guys, some of these slides have a lot of detail. Any of you that know me, I hate this much detail, especially on slides. But I felt like since I was picking all the critical access waivers out of the law, that I would put all the references and all the information there so that because you can find this same information on the internet, but it's not going to be specifically for critical access hospitals. It might be for any of the other 17 facility types that CMS has. But the ones that you're going to have here are uniquely for critical access hospitals. The rule on advanced directives has been waived. Once again, I do not think right now this waiver is something that we need. So therefore, if I were you, I would go ahead and follow what is in 489.102 on these advanced directives. Also, under physical environment, we have some flexibility there too, as far as where we treat our patients and the areas that are that we have flexibility. These are still in place. Whether your hospital is over capacity or not, this waiver is still in place that gives us the ability to service patients in areas that normally would not be serviced. And that is still in place. And if you still are utilizing that and getting benefit of that, you can still do that until the PHE is over. And unless you bump against a state requirement, the federal requirements here have been extremely laxed so that you can serve people and deal with surge. Next slide. Okay, on the telemedicine, I don't think we need to discuss this since this was discussed in the last session, and so I'm going to bypass telemedicine. And in fact, I do have a few slides at the end that pertain to some of the most recent legislative changes that we'll discuss. So I'm on back from there. But you want to go back one slide because I didn't address the nurse anesthetists. There we go. There we go. There have been some relaxed guidance on credentialing for nurse anesthetists, CRNAs, and that's still intact. And if you still need that, it's available. Once again, you need to check with the state of Florida to make sure that some of the state requirements don't come into play. But from a federal standpoint, you pretty much have some freedom that you didn't have before. Once again, if you don't need this, I would go ahead and plan as though the PHE is over. Next slide. There we go. Also, our emergency preparedness. As we all know, 485.625, which tells us that we have to develop a set of policies and address the need for surge in our emergency preparedness, that those requirements have not gone away, but we're not held to developing and updating that plan while the PHE is going on. This kind of just takes the burden off of saying, oh man, I got to deal with my emergency preparedness plans. Now, however, once again, I would tell you, unless it is a constraint that you have because of the public health emergency, I would go ahead and update and maintain your EPP plans as they should be. As you know already, the law tells you that you have to evaluate your risk assessment every 2 years at your hospital, and you have to modify your plan based on that risk assessment every 2 years. And so I would continue to stay on that plan unless the PHE has caused you to, that limits what you can do right now. The same thing is on some of the QAPI programs, quality programs. We still always need to have quality programs in our hospitals, but once again, the data-driven reports that we normally have to have, they have given us much grace in that area. And I would tell you, like I've said in some of the others, unless you're being affected right now with the PHE, I would go ahead and pick the QAPI requirements back up, which is 485.641 A, B, and D. Next slide. We also have some staffing issues for nursing. We no longer have to have the nursing care plans that are normally required under 485-635. And so that gives us some flexibility right now. Now, as soon as the PHE is over, we're going to go back to having to have nursing care plans. And therefore, if we got to have them, if we can do them now, I would suggest doing so. Because though we have all these waivers that, quote, help us, at some point when it goes away, we could be in a bind. Now, I do understand that right now we're having a staffing crisis, which makes it even harder. So this waiver that we have, you might have to live with this waiver until the PHE is over with, because you just do not have the staff to work through your care plans. Also, there are some federal requirements for critical access hospital personnel qualifications that have been reduced. And so now it's only at the Florida state level that we have to, that are governing our state licensure requirements. That from a federal standpoint, they pretty much laxed or reduced those requirements. But on a state level, you still have to abide by whatever your state says in that. Next slide. All right, guys, I apologize. You would think after 4 or 5 of these slides we'd be finished, but no, there's a lot of waivers. And some of you might not even have been benefiting from these waivers and could have. And I hate that that's the case, but that is the case. Okay, critical access hospital staff licensure. Once again, that's very similar, but this comes from the CFR 485.608. And this gives you enormous flexibility in your staffing models that you have. As long as you're consistent with the state emergency plan preparedness, you're in good shape. And so, and knowing what problems we're having, this is one of those areas of waiver that I suspect that you're going to keep into place until the PHE is taken away because of the staffing problems we have. Also, 485.610B, which talks about the locations that we can serve patients in. Well, that too has been taken away. As many of you know, a critical access hospital cannot have a department of the hospital that's within 35 miles of any other facility, yet it can't be any farther away than 35 miles from the critical access hospital. Well, those requirements have been taken away. And so we've been given the ability to have off-site or off-campus departments to meet the needs, even if they bump against another hospital's 35-mile area, or if they extend beyond our 35-mile area. We have those kinds of flexibility. But once again, when this is over, whatever facilities we are using that are outside of 35 miles or within 35 miles of another hospital are going to have to be pulled back. And so that's just something that you need to know. But the great thing is, whatever you're doing in this regard, you know you always have 60 days to make some adjustment, because they can't turn off the PHE without giving us a 60-day notice. Next slide. Maybe my screen has not updated, but I'm not seeing a change in that. Hopefully you are seeing a change.
I did switch the slide, Jeff. There's been a little bit of a lag in your video, but your voice is coming through clear. So it may just be a lag.
But guess what? It's not going to stop me. We're not going to stop. We're not going to stop because the video. Yeah, we're going to keep going. Okay, the next waiver is some of the physician requirements at the critical access hospital, as far as their specific presence that have to be there. Well, they have lacked that too, and it makes it so possible that physicians can give direction with phone and being remote, which has really been helpful. Oh, but don't build and live with that, because that's going to go away. There has not given us any indication that that's going to change, that once we leave this, it's going to require that an MD or a DO be on site and not be able to give direction remotely. So just be prepared. This is going to go away. Also, for our SNF units or our swing bed units in the hospital, as you all know, we have a 3-day hospitalization requirement for those to qualify for swing bed or skilled nursing care. Well, during the pandemic, the 3-day hospital, it still requires hospitalization, but it's not a 3-day hospitalization for us to utilize our SNF unit or our skilled nursing facility beds for that purpose. So if you're not already doing this, you should be. You don't have to have the 3-day requirement. However, you still have to have them being discharged. And so this too is expected to go away at the end of the pandemic. And the next slide, Keenan. Then the last waiver that I will address from the critical access hospital point of view is that the equipment that we've been maintaining, which comes from 485.623B, which says that we have to have these scheduled inspections and calibrations of our equipment and everything annually done, of which, as you all know, that when you are surveyed, both from accreditors or the state, they're looking for tags to show that those inspections, well, during the PHE, we have some grace in that regard. But once again, what I would suggest to you is, though you have this grace, let's think about this. If you don't use your own hospital's biomed department to do these inspections, I can tell you that when the PHE starts to come off, everyone is going to be calling those companies that do bio engineering and biomed inspections. They're all going to be called, and so you're going to be left hanging and vulnerable for survey. So I would suggest that if some of these are out of date, that you would go ahead and get those inspections scheduled now. All right. Well, let's go now to next slide, Ken. The next slide is dealing with the waivers that are dealing with the rural health clinic. We all know that 50% of the time at a rural health clinic, you have to have either a PA or a nurse practitioner or a nurse midwife available to take care of patients during that period of time. Well, that waiver has given us the ability that if that's not the case, we're not out of compliance. And so this has been a great help to many rural health clinics. However, there's not going to be any long-term correction on this. When the PHE is over, we're still going to be under those staffing requirements. Also, we have physician supervision of NPs in RHCs or FQs. This can be done without being on site, can be dealt with over the phone, and the documentation is not nearly as intense as it would normally be in a survey process while the pandemic is going on. But I would suggest that the medical director that's giving the supervision would immediately, not wait until the end of the PHE, to get back in the habit of giving the supervision to these that need that. Next slide. We also have, and this has been done, and you probably have done it, and if you haven't done it, shame on you probably, but we were allowed to have satellite locations. And when I say satellite locations, it was kind of like this. If I had a critical access hospital and I had a rural health clinic on the campus or close by, and yet I realized that because of COVID, I wanted to have two locations, one for COVID symptoms and other for other symptoms, then you could establish two locations, which in fact gave you the ability to basically have a rural health clinic with satellite locations. And so we saw hospitals do that all across the country, where you would have an RH, your traditional RHC, but you would open up a temporary, if you will, satellite facility somewhere else. Well, what that ended up doing is it allowed the hospital to see if location had anything to do with volumes. And they found that many areas were more convenient for patients, and therefore volumes increased. And so many of our clients now are asking us to help them start the certification process for new RHCs where they were using these satellite locations. What a great way to develop a new RHC. And while this is still going on, this is still available to you. So what I mean by that is, and let me give you a real Florida example, is if you in Florida have a critical access hospital and you have a RHC, and yet you would like to be able to at least evaluate expanding in another location, you can do that under this temporary expansion location. We can all bill it under the same RHC while the pandemic is going on. You can get paid as an RHC, but in that process, it will also give you the time period to start the certification so that you can now have multiple RHCs. So if you're not doing this, I don't know how much time we have, but it is something that many of the critical access hospitals across the country have utilized this provision. Now, here's what's going to happen. Let's say that on the 14th of August, they tell us that at the end of this extension, it will not be renewed. Well, whatever you have been doing in that regard as a satellite location will end at the end of that period of time. So you might have to address those things and be prepared for that, because if at the end of, like I said, the magic date on this 90-day window is August the 14th. And so if they tell us on August 14th that it's not going to be extended, they have given us the valid 60 days that we have to have. If not, we're always waiting for that next 60 days, because that's the only guarantee we have is 60 days. Okay, the next slide, please. As I had already said, there are, at the end of the PHE, there's no waivers. So that means that when we're finished, if you haven't been staffing 50% of the time with a PA or an NP, you're going to be out of compliance, and you're going to have the potential of having a condition level deficiency, which means you have only 45 days to remedy that, or you're going to lose your certification. So these are some of the things that have to be done. And we've got to have the medical director in his role reviewing charts and managing the policies and reviewing those policies, and having the RHC providers working from home and using telemedicine from the house. That's no longer going to be available. So all these things are things that are going to end shortly. Next slide, please. Okay, what I had talked about earlier, that when this thing's over, that means no satellite or off-site RHC locations. And so that you need to be prepared for that. And also, if you are using a satellite location, right now, it wouldn't really matter where it's located. But if that satellite location is going to be something you're striving to have it one day certified as a RHC, it better be in a HIPSA. And we need to make sure the HIPSA is current and is not subject to removal. Because until you become a certified rural health clinic, you do not have the grandfathering provisions in case you lose a HIPSA. So all of these things need to be addressed before the PHE ends. Next slide. This is an area that's a big thing that needs to be addressed. And I think I shared this on one of the webinars recently. If you, being a critical access hospital, if you have RHC, that means it's probably a provider-based RHC. And provider-based RHCs had an uncapped rate on their all-inclusive rate until 2020. And in 2020, it was determined that whatever your rate was calculated that year, that is your cap from now on. That's your grandfather rate. However, 2020 was also the year that we had, under this waiver, we did not have to comply with the productivity standards. So let me give you an example. If you have a rural health clinic that has not been meeting the standards, in 2020, if your cost report preparer applied for the waiver, they were not under the productivity standard. Therefore, your rate and your cap was higher because you weren't limited by the productivity standard. So that means you're excited today because you have a rate that is high, so that your all-inclusive rate is great. However, if your volumes and costs don't match with that new rate, as soon as the PHE is over and the productivity standard falls back into place, you're going to find that it is almost virtually impossible to hit the same rate cap that you had before. And as we remember, how this works is you take your total cost and divide it by your last year's encounters. However, if those encounters don't meet the productivity standard, they're going to divide your cost by the productivity standards, which obviously, just by thinking through that, if they're higher, if my denominator is higher, it's going to reduce my rate. And so we all need to be careful, knowing that when this PHE is over with, the productivity standard is going to be in place. Now, we've always been able to waive the productivity standard. And when I say we've been able to request the waiver. But during the PHE, the waiver was always granted. And usually you had to have extenuating circumstances to get the productivity standard waived. Well, when the PHE is over with, we expect many people would be wishing that the productivity standard are waived. However, it's going to make it where what their all-inclusive rate was this year, it'll be less next year. And so you need to work with your cost report preparer, and y'all start working through what is it going to take to keep my high all-inclusive rate intact. Next slide. Okay, this, I told you we would come back and talk about telemedicine. What about medical telehealth after the PH ends? There's always been this discussion. The flexibility was given that telemedicine would not end until at least December 31 of 2024. That is because the last Wednesday in July, the House passed HR 4040, which basically says that it won't expire on the 152nd day after the PHE is over, but it'll now go all the way through the end of December of 2024. Now, this legislation has not been put in the books, but it's expected to be signed, and if it's not already been signed, and so that means that our telemedicine, both distance and origination site, as we have it today, will stay intact until at least the end of 2024. Now, that is not what we desire. We desire, because this is a rate of $90-something. It's not our all-inclusive rate for that. It's that's not what we would all desire, but this is what the House passed. And so we feel like that this is what we're going to live with. We're still fighting to see, we would love to see them change the law where we can be distance and origination site and get our all-inclusive rate for these services. But as of this moment, that's not available. Now, this is all for primary care. For mental health, we have already seen the change in this year, in 2022, that we now can do telemedicine mental health and get our all-inclusive rate. And that will not be modified when the PHE ends. And that's exactly what the next slide, you can go ahead and go to the next slide. That's exactly what the next slide is basically saying, is that the Medicare physician fee schedule update final ruling that came out said that mental health now can be a distant site and we can get our all-inclusive rate. So, and there's the data where to go to get those details. Okay, then the next slide, please. Okay, on this slide, I'm dealing with the unwind. As soon as the PHE is over, your Medicaid patients are going to be in a frenzy because we have been told that all the laxed qualifications for Medicaid that have been in place are going to go away once the PHE is over. And looking at that unwind, I would suggest that you're going to see a large scale of patients lose their Medicaid insurance. And I would suggest as a hospital right now that you start talking to your Medicaid patients as to what they might do and what they might consider. And they need to go and find out what's going to happen to their insurance. Because what has happened up to this point is if you lost your job at the start of the PHE and went on Medicaid, you might have gotten a new job since then, but you were still able to stay on Medicaid. And so Medicaid effectively grew during the PHE in Florida. But it was a false growth because as soon as the PHE is over, we're going to go back to the same rules, and which could cause really a lot of grief. And so I would suggest that you start counseling with the patients that you have so that they might see what they're going to have to do to qualify and which children would qualify and which children would not qualify, because that's going to come about in short order. And I would love to say that Florida is going to come in here and give some relief, but I have no indication of that. I have looked and looked and looked. It looks like the true unwind is going to take place. And I'm telling you, it's going to take a lot of your patients by surprise when they find out that they don't qualify for Medicaid. And so their benefits going to immediately be terminated. And so there is a major concern, and I don't see any grace period in this thing. So as long as we stay in the PHE, we're okay. But I would start even now discussing this with patients as to have they reached out to Medicaid to see what is going to happen at the end of the PHE so that they can be prepared for it. Next slide. This slide just tells you what was already talked about in the last presentation as to the HCPCS codes that you would use for mental health as far as what's available with those new mental health telemedicine rules. Next slide. This was an email that we sent out to many of our clients, and we definitely wanted, with all of you on the phone, to know that Florida is requiring you to revalidate your MPI. And we put a link here on the tool to use to do that, but Florida is requiring all the Medicaid contractors or providers are required to update their MPI number with the proper taxonomy codes. And so please follow these guidelines and go there. We don't want you to be caught off guard when this takes place. Next slide. This is the actual Medicaid alert that came out on this NPI change. And if you did not see it, we wanted you to have that so that you could see what's going on. Let me just explain what's happening here. This is going to really help you because by updating the NPI correctly, it's going to give the state office the ability to really see where the underserved areas are in the state and make sure that that we can keep some of the HIPSAs, the shortage areas throughout the state, and you're going to need that. And so please do this, and here is the alert that's right there for you. I believe, Keenan, that I have tried to finish within 4 minutes of my deadline.
You did
I have
excellent
gone
job,
at a
Jeff.
speed of light, but I would welcome any questions at this point.
And I was just about to say, let's open it up for questions. I know Peter just made a good comment about a lot of the critical access hospitals having questions about the NPIs in their site visits. So I'm sure that might be a topic that some might have further questions on, but the time is open for questions. If anybody has any.
So Jeff, just one question, and it's my usual question. So if there's one area where you would recommend the critical access hospitals to focus in relation to these unwinding of these waivers, what do you think is going to be the single most important, single most impactful thing for them to look at?
Well, Peter, I think number one is if they are considering expanding their services, if they have rural health clinics in their critical access hospitals, while the PHE is going on, is the time to do it. Even if the PHE is terminated before they can get it all finished, it will have been such a benefit to have that PHE, because what that basically means is I can bill providers in another location and get on my all-inclusive rate while I'm trying to get fully set up and certified as a RHC. Well, you couldn't do that without the PHE going on. You would have to go and start as a fee-for-service clinic most probably and wait for all the bells and whistles to take place before you could become an RHC. As it is here, we could start billing as an RHC without being one while the paperwork is being filed to be certified. That's a benefit that many critical access hospitals should be utilizing if they're wanting to expand their primary care service area. So that's one area. And then the other thing that I would consider is be prepared for the staffing issues. You better start working on those, and the productivity standards. You better start both staffing and productivity. When those waivers come off, it's going to hurt us bad if we're not prepared.
Great. Thank you so much. And any other questions, please put them in the chat. I know that or send them to Jeff. I know that Jeff's always really willing to answer and respond to things in emails, so that's great. I'm just in the interest of time, excuse me, as we come to the end of our time period. Leela, are you still on the call?
I think Leela jumped off the call, actually, Peter.
Okay, no worries. So what I will do just to close us out, and what we will do, one of the things we're going to do, obviously we had to pause the recording. What we'll do is once I've closed out here, we will resume the recording from Michelle and get the rest of those in, so at least we can have it all in one in the one recording for that side of things. But I'm going to say that this recording will be uploaded to the to the Flex website in the next few days. We'll be sending out an email about that. As Keenan said before, we'll be sending out a satisfaction survey for everybody to fill in, who's a participant on these things. And again, for those critical access hospitals, we are in the process of finalizing your CEO reports as the sort of final component of the Flex program for this grant year coming through to August 31st. So there'll be some recommendations that come out of these last 2 days as applicable to you as hospitals. And we're going to look to include some of that stuff from Jeff raised, some of the stuff that Kendra raised, some of the other great points that were raised in the things last week. So we're great with that. And again, please do get in contact with us if you have any further questions you want to raise, and we'll push them out to the relevant parties. So with that being said, feel free to drop off, or if you can hang on for, I think what have we got, about another 6 minutes or so of that video, Keenan? Just about. So it'll be pretty quick. Okay, great. So with that being, I'll give it. Anybody want to add any other questions, thoughts, comments before we recommence the video?
Peter, one other thing is, one of the hospitals have asked me since our last talk, and I just thought it would be good to reiterate that, is I was making some mention that you should be utilizing your RHC providers in the nursing home. However, if you are doing that in the nursing home, the chart has to live in the rural health clinic, because it's an encounter that we're getting paid for, and encounters have to be documented with a chart. And so we can't leave it in the nursing home. It's got to be in the rural health clinic. And so we had some of the Florida hospitals contact and say, hey, we want to do that with our RHCs, but the note's going to live in the nursing home. Well, if it is, then it doesn't count, and you can't use the all-inclusive rate. Yeah. So if you want the all-inclusive rate for your RHC while your providers are in the nursing home, then you better keep a record on the note or the chart in the RHC. And I just want to make that statement so that all the hospitals that are listening understand what is needed and what's required.
And so there may be some degree that they may have some technology thing to make sure that access to the EHR is available in the nursing home or the the facility, the skilled nursing facility that's happening, in order to be able to support that requirement.
Yes.
Yeah. Okay. So that's just something to consider, is that you will do that. Okay. Well, thank you very much for that, Jeff. We'll make sure that that gets noted through on those things. So Keenan, if you want to recommence the video, we can play us out with this session.
Perfect. Thank you, Peter. And before I start, huge thank you to both Kendra and Jeff for jumping on and putting together these slides for today, and just for being able to come in and share their expertise in these areas. And I know it's much appreciated, and this recording will live on, and it'll continue to be viewed. So we appreciate your time. And so I'm going to start the video. It looks like we got about 6 minutes left, and you're free to stay on if you'd like. If not, it'll be in the recording.
As you're building your telehealth strategy, and others may talk about this through this summit today, look at both your setting up your infrastructure. And when we say infrastructure, we mean basis. What is your technology? Is it going to function to help you bill some of the services? Not only is it going to be able to do a video visit, but can it do it secure messaging so that you can bill for some of those other virtual check-in types of things that we talked about, and the other virtual messaging? Governance, putting your governance in place on how you're going to decide which services are going to be utilized by a telehealth to help your organization develop the clinical guidelines. That doesn't need to be super complicated. That can just be a couple of people in a room deciding how we're going to do this, and that's your governance. As long as you've got this happening from a structured perspective, a consistent perspective, that's all you need from a governance perspective. You don't need to have a big committee if that's not something that your organization typically does. What are your operations? And then really identifying your partners. Who's going to partner well with you? and be able to help you be able to extend your telehealth services potentially back and forth, depending on if you utilize the credentialing by proxy.
That also could include remote patient monitoring partners, vendors who not only focus on the technology but the workflows. So just keep in mind all those various partners. And in the rural health community, we also see partners such as your community paramedicine, your EMS. So identify those partners within the community, within other healthcare organizations, and vendors who are in the space to really connect with patients and with technology.
Yeah, and I know that we're running short on time, so I wanted to make sure that you knew, obviously, your TRC, Lloyd, who is just on, is the director of the Southeast Telehealth Resource Center, and that's your resource center, but any of these resource centers are helpful, and you can look at some of your national consortiums and national resource centers to help you with technology selections, as well as public policy. And interestingly enough, the Southwest Telehealth Resource Center is doing a session on the impact of the new physician fee schedule, the impact on rural health. So this will be held on August 16th at 12 o'clock at 1 Mountain. So register there. This is on the Southwest Telehealth Resource Center's site. And I'm guessing, Lloyd, you might be able to link that over from the SETRC so that folks can register for that one. It should be a good session. There's also some great resources on helping you with practitioner support, policy, and advocacy. This is the National Digital Inclusion Alliance, and there's some really great resources in there to be able to help you with your telehealth journey. And finally, when we look at, and I say finally, there's another slide here too, but access for seniors, how do you bridge the gap for digital literacy? We're seeing a lot of work around patients accessing telehealth. Not only is broadband a challenge, but we're also seeing a real challenge around digital literacy. So we're seeing some of these programs come together to help people understand how to use a digital device. And that could be not related to healthcare. They just teach them how to get on Pinterest, how to do a FaceTime, how to get on Facebook and do Facebook Messenger and things like that that would be helpful to them in their everyday social life, and they can use those skills to be able to get to their healthcare provider. So some helpful resources there. Also, if you're looking at your patients and they don't necessarily have technology in the home, these are other resources that you can utilize that will help you to access broadband and also digital devices and digital literacy training. And finally, TrueConnect, it gives you some free device and wireless internet. So again, these are already programs that are in place. You only have to be eligible if you're currently on SNAP or WIC or anything along those lines, currently in public housing. So there's a lot of criteria there that allow you to reach a lot of your patients, and they can get wireless service as well as devices for very inexpensively or even free. Also, Starlink, for those of you that are in a really rural area, we know that these satellites are going up all the time. Sometimes there's 50 at a time that are going into the stratosphere or wherever exactly that is. But we know that not only is Starlink into this, but now we're seeing companies like AT&T starting to use their DirecTV model and the internet and the satellite TV that they may have already in your home or in your patients' homes. For satellite and digital technology, they can utilize the DirecTV as well with AT&T. So lots of work that's being done around increasing high-speed broadband, and I know some folks that are utilizing this in the northern Michigan area, which is very rural, and they seem to be happy with the service that they're getting from Starlink. So I think we'll see DirecTV, AT&T hot on their trails. We know that Office of Broadband, Florida Office of Broadband, is very helpful as well. They can help you with your technology planning, as well as targeting for rural underserved programs through grants as well to help you move forward. So I think we may have gone over just a little bit. I'm so sorry about that, but thank you so much for having us. I am Michelle Hager. This is my contact information. Please feel free to call me or email me anytime. Also follow us on LinkedIn, Twitter, and Facebook. We do webinars for free every single month, and Christy is also going to be available for questions. Thank you so much.
Thank you.
All right. Well, I think that does it for us, and that's the video. So that wraps up the conference day 2 for the Florida Flex Conference.